Good morning, welcome back to Open Med School. Today I am coming with a very important topic, acute flacid paralysis. How to localize and how to approach a patient, a general view, that is today's agenda. So, what is meant by acute flacid paralysis? The disease should be acute in onset, so over a short period. Second, the duration is less than 4 weeks and maximum severity occurs in days to weeks. There are a number of differential diagnoses and let us see how to approach such patients. Go by anatomy. The problem can occur at the level of brainstem. When typical example is brainstem encephalitis or a Guillain-Barré syndrome with cranial nerve involvement. So, this may be the first thing to be kept in mind. When there is cranial nerves are involved, when there is an acute flaccid paralysis, think about localization starting from brainstem. Second is spinal cord. So, the spinal cord, the classical condition is the transverse myelitis. There is a transverse cord lesion. So, the initial period there will be spinal shock or a neuronal shock that leads on to flaccid paralysis. Next level is in the level of the anterior horn cell. The classical disease that we come across is poliomyelitis, and with the eradication of polio, some enteroviruses can also produce anterior horn cell disease or polio-like syndrome. So, anterior horn cell disease can be polio or non-polio enteroviruses. Then comes the nerve roots. In the nerve roots, the classical disease is the Guillain-Barré syndrome, polyradiculopathy produced due to GBS. Then peripheral nerves, again GBS, toxic neuropathies, especially diphtheria, tick paralysis, poisoning with the lead, arsenic. One very important differential diagnosis is acute intermittent porphyria that can imitate GBS, critical care neuropathy. So, these are the things that should be considered at the level of the peripheral nerve. Then comes neuromuscular junction. The classical disease is myasthenia gravis. Remember, in our place, snake bite, kite and cobra. The history may not be there and it may present like an acute flaccid paralysis. Acute paralysis that is occurring in organophosphorus poisoning, acute neuroparalysis, and later you can get the intermediate syndrome, that also is flaccid paralysis. Then comes at the level of muscle, polymyositis or dermatomyositis, polymyositis can present with the weakness. The most important condition to be remembered is hypokalemia. So, the potassium, increased potassium and decreased potassium both can lead on to muscle paralysis, especially with the use of ACE inhibitors, ARB in patients with renal dysfunction. They may precipitate hyperkalemia and can come with the acute weakness. Rarely hyperphosphatemia, that is not very common. So, we think in the hierarchical order. First is upper motor neuron. So, even though the classical description human lesions produces spasticity, in the acute phase this may present like a flaccid paralysis or like a LM lesion. So, the sites of lesion for acute flaccid paralysis can be brainstem, spinal cord, anterior horn cell, roots, peripheral nerves, neuromuscular junction and muscle. So, this is the order in which you should think about when a patient comes with motor weakness also. So, once you have seen a patient with a acute flacid paralysis, the first step is it LMN or UMN? We all know LMN is the final common pathway that supplies the muscle. For example, here it is the skeletal muscle is supplied by the anterior horn cell, and from there the neuron is starting and supplying. So, that is the lower motor neuron. The neuron that is controlling this is the upper motor neuron. So, typically we take the pyramidal tract as the example of the upper motor neuron starting from the corticospinal tract. The same way the neurons are there in the brainstem, they are the equivalent of the spinal cord anterior horn cells, that is the cranial nerve nuclei. So, they are also lower motor neuron and they are controlled by upper motor neuron. The pathway is the cortico-bulbar pathway. So, remember, cranial nerves are also part of peripheral nerves. So, any disease that affects the peripheral nervous system can affect the cranial nerves also. That should be kept in mind. And we all know the classical findings of UMN and LMN. For a discussion, please see the video on LMN UMN lesions. So, when somebody comes with an acute onset paralysis, how will you approach it? There are different ways. So, one thing you can look for is whether there are any features of spinal cord compression. So, the best way to identify a spinal cord lesion is look for sensory level. So, that is a very important point to be looked for. Sensory level on the trunk. So, remember, nowhere in the neuraxis you get a weakness of upper limbs and lower limbs, that is paraparesis or quadriparesis with a sensory level on the trunk. That is, if there is a sensory level on the trunk with para or quadriplegia, the site of lesion is always spinal cord. It cannot be peripheral nerves. So, they can differentiate a GBS from transverse myelitis or spinal cord compression by looking into the sensory level. So, the first point when somebody comes with the para or quadri, look for sensory level on the trunk. Hope this is clear to you. So, if there is a sensory level, the next step you should be doing is you examine the spine and rule out a compressive myelopathy. For that you can go for a MRI. If there is sensory level is there, it is spinal cord lesion, then you divide into compressive versus non-compressive. For that you should, an imaging is a must. And if it is a compressive lesion, refer the patient to neurosurgeon and plus or minus steroids depending upon the situation. If it is if the MRI is normal, it is a acute transverse myelopathy or transverse myelitis and treatment is high dose steroids. So, that part is over. So, again fundamental thing, somebody comes with the acute flaccid paralysis of lower limbs or upper limbs and lower limbs, that is para or quadriplegia, look for carefully for a sensory level on the trunk. Sensory level is there, ask for an MRI. Depends upon the MRI, you decide whether it is a neurosurgical problem or a medical problem. If there are no sensory level, next step, very important thing is look for the deep tendon reflexes. That is one thing. So, if the reflexes are absent, no sensory level, and if it is symmetrical, bilaterally symmetrical, it is consistent with the GBS. So, in short, GBS is a symmetrical involvement, ascending type of paralysis with hyperreflexia or areflexia. So, it is a symmetrical ascending type of paralysis which is areflexic. The diagnosis GBS and think about the further management of the GBS. Again, a GBS like presentation, look at the ocular muscles and the bulbar muscles. Carefully examine the facial nerve because bilateral facial paralysis can be easily missed. If there is a facial involvement or ocular muscles are involved or the pharyngeal muscles, that is difficulty in swallowing is there, think about myasthenia as the first possibility. especially if bulbar symptoms are dominant. Think about myasthenia, botulism, and rarely snake bite. So, these are so it's very important look for upper limbs, lower limbs. In addition, examine the bulbar muscles and the eye movements. If they are also affected and it is a predominant feature, think about not about GBS, but about more chances that it is likely to be myasthenia. Hope this point is clear. And you may go for a serum potassium. Is very important. One of the important investigations to be done is checking for the serum potassium, because hyperkalemia can present as just like a GBS. And in a young patient, always check the urine for porphobilinogen. Acute intermittent porphyria is a great imitator. That should also be kept in mind. And if the findings are asymmetrical, think about polio or polio-like syndromes, that is anterior console disease that can be by some enteroviruses. And some amount of asymmetry can occur in GBS. So, by definition, GBS should be bilaterally symmetrical in at least 2 limbs. So, there can be some asymmetry can be there. Then only significant asymmetry, only one limb is affected. You have to think about injection neuropathies, some trauma or toxins like lead poisoning. So, this is an overview how to approach a patient. Hope this point is clear to you. And some patterns should be remembered. For example, flacid quadriparesis with a sensory level, we have already mentioned, with early bladder, it is transverse myelitis. So, one of the differential diagnosis of GBS is transverse myelitis. Here we will be looking for is, one is looking for the sensory level, early bladder, and there plus there is a weakness. So, this is an important pattern that should be remembered. Second is flacid afebrile symmetrical para quadri plus minus bulbar symptoms. So, this is typical example is the GBS. So, it is I already mentioned bilateral symmetrical reflexic paralysis. There can be some involvement of the bulbar muscles also. Usually there is no significant sensory findings, but can have minimal sensory findings, but usually there will be some sensory complaints. So, objective sensory findings are less, but subjective symptoms can be there. So, most important condition, Guillain-Barré syndrome. So, it is a flacid, remember it is a febrile, the patient will not have any fever. So, 2 to 3 weeks back there can be a febrile illness, because many of them are precipitated by some viral illnesses or Campylobacter infection. So, very important point, the patient be asymptomatic except for the weakness. The anterior console disease already I mentioned, the flacid, usually they will be have febrile illness. They are pure motor, no sensory complaints, and it is always asymmetrical. So, this is how you differentiate a GBS from polio or anterior console disease. Asymmetrical, the patient can have some constitutional symptoms, no sensory, purely motor. Next comes the flaccid motor bar sensory, monoparesis. So, one limb alone is affected, upper limb alone is affected, lower limb alone is affected. You should ask about history of some injections. So, you can see the sciatic nerve can be injured due to injection neuritis, pressure palsy, trauma, all this can lead on to this sort of pattern. Already I mentioned about the predominant bulbar symptoms, ophthalmoplegia, ptosis, bulbar weakness plus motor weakness. One you should think about myasthenia, already mentioned, snake bite, botulism, organ of phosphorus poisoning, and very important condition, keep in mind, the Miller-Fisher variant of GBS. So, it can also produce the same sort of symptoms and also brainstem encephalitis. So, predominant cranial nerve symptoms, think about possibilities like this, starting with myasthenia. Proximal muscle weakness with muscle pain or muscle tenderness. Think about dermatomyositis. Steroid-induced myopathy can also have proximal muscle weakness, but tenderness may not be there. With the pain, another important condition is the osteomalacia producing proximal muscle weakness. So, this should be when there is a predominantly proximal muscle weakness, think about conditions like this. Then now how will you investigate? Already I mentioned about the major investigations. If you are thinking at compressive myelopathy, always go for a, or as transverse myelitis, do go for a MRI. X-ray cervical spine is important when you are suspecting atlantoaxial subluxation. Electrophysiology in case of GBS, and also for in myasthenia and critical and other myopathies you can go for. When you are suspecting electrode imbalance, always check the potassium. Periodic paralysis and hypokalemic or hyperkalemia induced paralysis. A lumbar puncture is indicated to look for albuminocytological dissociation. That is, in GBS usually the protein is elevated, but the cells are not. That is what is called albuminocytological dissociation in the CSF. Always check potassium. Already I mentioned magnesium and phosphate in necessary cases, and CPK, creatine kinase, when you are suspecting poliomyelitis. Never forget to take an ECG and urine porphobilinogen. Any suspected case of GBS, if some atypical things are there like hyponatremia or ankle jerk is preserved, in such cases do not forget to check for the urine for simple Watson-Schwarz test can identify. Management depends upon the specific diagnosis. In GBS you go for IVIG. In transverse myelitis you go for medial prednisolone. In compressive myelopathy you go for neurosurgical intervention or steroids, depends upon. In dermatomyositis and myasthenia go for immunomodulations. In hypokalemia is eminently treatable, always remember that. And any case of acute flacid paralysis, look for respiratory muscle weakness, bulbar muscle weakness. Patient can have hypotension due to reduction in the vascular tone. And so, think about the autonomic instability, think about the complications of immobilization, prevention of deep vein thrombosis and nosocomial infections. So, this is how you approach a patient with a flacid paralysis. So, we have discussed about an approach to acute flacid paralysis, what is the definition, what are the major causes, what are the patterns. So, take home message is acute flacid paralysis is usually within 4 weeks and can be human type and element type, and never miss compressive myelopathy, hypokalemic paralysis, and when the bulbar muscles are affected, think about myasthenia, Miller-Fisher variant, and the rare possibility of snake bite and organophosphorus poisoning. Hope this was useful. Individual cases will be discussed in much detail in the following sessions. Okay, thank you. Bye.